to chime in and unmute yourself. And I'd love this to be a very interactive fireside chat. So I have no conflicts of interest to declare. So in today's talk, I'd like to outline my journey to becoming a neurosurgeon scientist, how it starts in the beginning with the schooling and the education. My journey is somewhat circuitous. I did kind of multiple different things before I became who I am today. And I'm still kind of a work in progress in terms of my career development. So, happy to share thoughts from the audience and questions about, hey, do I have to do it this way to become a physician? Do I have to do it that way if I want to do research? So these are a lot of questions that I think a lot of mentees who I mentor often ask me. So, please feel free to unmute yourself and, have any questions, please ask.
Yeah, I'm here.
And I thought I would, yeah, is that Frank? Sorry. And, and then I thought I would talk about, a little glimpse into the life of a neurosurgeon scientist. And then I'll present some patient cases. So these are cases that common things in neurosurgery that I treat, both as a neurosurgical oncologist and more of kind of a general neurosurgeon. And I hopefully offer some words of advice to the audience, those who are interested in pursuing a very long journey to becoming a neurosurgeon scientist or even a physician scientist. So let's get started. So my journey really, has taken me all over North America. I started my my undergrad at the University of British Columbia in Vancouver, BC, where I did my undergrad,
go ahead.
medical school, and my PhD. And then I did my residency in neurosurgery at the University of Alberta in the plains of prairies of Canada. And I just kept moving east and really had the honor and privilege of doing post-grad training and my fellowship in neurosurgical oncology and spine at Harvard at the IDMC, the Beth Israel Deaconess Medical Center. And it was through the mentors that I met at Harvard that I was able to segue into doing a cancer biology postdoc at MIT at the Koch Institute for Integrative Cancer Research. And I took a segue away from clinical medicine for a bit and really focused on being back at the bench again and kind of reestablishing my passion for being at the bench and doing research in basic science and translational cancer biology. And all of that really allowed me to then, during the pandemic, who knew we would have a pandemic, enter back into clinical medicine and surgical medicine at McMaster University in Ontario, one of the most research-intensive universities in Canada. And I was able to be a pre-faculty attending surgeon at McMaster University and have the opportunity to partake in some translational neurosurgical research, which I'll talk about later on in my talk. And after the pandemic, after the borders reopened, I came back to the US and had the privilege of completing my fellowship with some excellent surgical training at Northwell Health, one of the largest healthcare systems within New York State. I don't know if anyone watches Netflix, but Lenox Hill and that very well very popular show on Netflix is all part of the Northwell Health system. And finally, currently I am a staff at St. Elizabeth's Medical Center in Boston, and I've had the privilege of being an attending there for several months now, and I'll show everyone a kind of a glimpse into that life of an attending that I've been experiencing over the last several months. But let's start with my early forays into neuroscience. And my PhD was based studying the mechanisms of beta amyloid clearance in Alzheimer's disease, which is one of the most well-known neurodegenerative disorders of the brain. And my PhD thesis was studying mechanisms of how what is thought to be one of the toxic peptides that causes neuronal death in Alzheimer's disease, this beta amyloid or A-beta peptide. My PhD was studying how neuronal cells made this protein and how it was shuttled throughout the cells to then affect this toxicity that we see in Alzheimer's disease brains, where the neurons will die because these beta amyloid plaques, they become insoluble in the extracellular milieu and they cause toxicity. And early on in my PhD, I made the discovery that a certain class of inhibitors was able to increase the secretion of beta amyloid in certain through the P-glycoprotein or the multi-drug resistance pump. And drugs that inhibited this protein transporter was able to also decrease the efflux of beta amyloid in certain cells. And so this was a discovery that I made early on that ended up becoming patentable. And through the Intellectual Properties Office, my PhD supervisor, Dr. Peter Reiner, and I were able to be co-inventors on several patents for this technology. And it gave me kind of an early taste for translational neuroscience. And early on, and this is quite early in my career, Dr. Reiner, my PhD supervisor, became the president and CEO of a biotech company based on my research that was able to do drug discovery across multiple different platforms to find targets to treat Alzheimer's disease. So this was very exciting as a young graduate student to be able to have a taste of what you can do when you work hard at the bench and you make a discovery, leads to intellectual property, and then actually leads to the spawning of a biotech company. So that was an early on taste of what being a translational scientist, neuroscientist, is all about. And I had the privilege of doing that because of really good mentorship. Sometimes we ask ourselves, for those of you who are researchers, who are at the bench, who are spending hours on ends of days and weekends at the bench, does anything I do actually make a difference? Does it really hit a mark? Does it is my discovery actually long lasting? Well, who would have thought that a little discovery that was made back in 2001 when I was published this as a graduate student is still something that is quoted on 20 plus years later as a classic canonical mechanism of how cells will clear this beta amyloid peptide through P-glycoprotein. So that's also really exciting to really put a lot of effort into the research that we do as scientists in hopes that other labs will start looking at and also working on these hypotheses, and one day as a global community of researchers really hone in on possibly finding a cure for something as devastating as Alzheimer's disease. But after my PhD and my medical school, I really chose to move towards neurosurgery versus neurology or other types of neurosciences. And that led me to do a very volume intensive neurosurgical residency at the University of Alberta. And I got some excellent neurosurgical training there. It was largely purely surgical and very little research. But having that PhD background and having done that research early on allowed me then segue into doing a more competitive academic fellowship at Harvard. And I was fortunate enough to have that opportunity to be mentored by really excellent surgeon scientists at the Harvard BIDMC program that taught me a lot of great techniques in complex spine and spine oncology. And I was able to enter the biomechanics labs just down the street to look at cadaveric bioengineering and biomechanical studies, looking at carbon fiber cages and interbody cages, a lot of bioengineering, which was super exciting as a basic scientist for me to be able to move into the bioengineering space was really super cool. Very, very grateful for having had that opportunity to broaden my knowledge and be able to understand, the types of techniques and tools that I was using in patients was actually able to be studied at kind of a more biomechanical and bioengineering level. So that really also broadened my horizons and allowed me to then, through mentorship, be introduced to the opportunity of having to do a cancer biology postdoc at MIT. And it was during that time at MIT that I was able to really build my skills as a neuro-oncology researcher. And I was really given a lot of free reign and great mentorship and tools to be able to study one of the more aggressive diseases, brain tumors. And this is a MRI image of a patient with a glioblastoma, or GBM, one of the most aggressive and unfortunately most common primary tumors in adults. And the current standard of care treatment for GBM, and also put a pitch because this month is GBM Awareness Month for the National Brain Tumor Society. And here's a patient who has a GBM, and on an MRI, the GBM lights up when you give a patient gadolinium contrast, and you try to do maximum safe surgical resection without harming the patient neurologically. The patient is then treated with radiation therapy and temozolomide, which is the DNA damaging agent. And what we know is without any treatment, and you do a biopsy, the survival for a GBM patient is very dismal, less than a year. With extensive resection alone, the survival only maybe at best improves by 15 months on average. But with extensive resection and radiation therapy, the survival can extend to as much as 2 or 3 years. But with maximal safe surgical resection, combination chemotherapy and radiation therapy, you can sometimes have these long-term survivors, but that's also very rare. So there definitely is an unmet need to be able to address this disease and find novel treatment approaches. And it was really, the opportunity to be able to work with excellent mentors, including, Professor Scott Floyd, who was a radiation oncologist at Harvard at the time and now runs a lab at Duke University, and my mentor, Professor Mike Yaffe, who's the head of the Department of Biology and the head of the clinical investigator program at the Koch Institute. The two of them really allowed me to really broaden my mind and develop these intracranial orthotopic xenograft models of GBM. And the technology platforms at the level of MIT really allowed me to be able to visualize what exactly is going on when you generate a small animal model of GBM using a small MRI machine where you can detect the growth of the tumor, and use other types of tools that also allows you to visualize the growth of the tumor, track the tumor growth when you're treating them with either common known drugs that treat these tumors, or or novel therapies that could further the survival. So, a lot of this technology I was able to harness when I was at MIT, and learn these tools allowed me to publish some really interesting papers with great collaborators across the university, and allowed me to really learn what we can do in terms of modeling GBM in small animals. And, through other mentorships with Professor Paula Hammond, who's the head of chemical engineering at MIT, I was able to work with bioengineers to develop nanoparticles to test delivery of drugs across the blood-brain barrier in these small animal models of GBM. And here we have a confocal in vivo microscopy that shows tumor cells in green in the brain of a mouse, and anything that's in cyan are these nanoparticles that Dr. Hammond's lab developed that is able to cross the blood-brain barrier and attach these glioma tumor cells in these mice. And we can deliver novel therapies that hopefully can translate into the clinic and hopefully improve the survival of GBM patients. And then furthermore, with a mentorship from Professor Angela Belcher, who's the head of BE at MIT, her lab's really expert in looking at near IR imaging modalities to be able to detect tumors at an early stage. And we were able to leverage that platform and work with a very talented graduate student, Yuanga Sadev, and develop this tool to be able to monitor these brain tumors that we can develop in these mice, and in hopes of using this tool as a surgical resection tool that can then be translated into the OR, which is something that I'm interested in as a surgeon scientist. And so, a lot of these tools really allowed me to develop skills to be able to develop a multimodal preclinical pipeline for neuro-oncology research. And it's allowed me to then segue after that, into a more translational neuroscientist, neurosurgical scientist position. When at the beginning of the pandemic, I left Boston and went up to McMaster University in Canada and had great mentorship there as an early faculty attending neurosurgical oncologist in to be able to also study other different types of models of brain cancers.
Right.
And one model that I was able to study while I was at McMaster through the mentorship of Dr. Sheila Singh was to develop mouse models of brain metastases. So while GBM is the most common and aggressive primary tumor in adults, actually most of the cancers that we see in the brain are due to brain metastases. And the big three primary cancers that cause brain metastases are lung, breast, and melanoma. And these are 10 times more common than primary tumors. And the current era of targeted therapies are very effective at controlling systemic disease. So a lot of these primary tumors in the lung and the breast and the skin are very well controlled. But what is happening now, we see this more and more often, even in my clinic, and I'll present a patient that really echoes that, is that patients then present with distant brain metastases. And once the patient develops a brain metastases, the survival statistically usually is 2 to 5 months. So again, we have to really attack it from the research level to address this unmet need for novel therapeutics. And so there's this whole cascade that we know that is very well studied, developed out of Dr. Bob Weinberg's lab at MIT, this EMT or epithelial to mesenchymal transition, where these lung tumor cells or these breast tumor cells or these melanoma skin cells will escape their primary site, travel in the bloodstream, and land in the brain. And this cascade can be studied at the small animal model. And through the mentorship of Professor Sheila Singh, who's in the Department of Neurosurgery at McMaster, and a very talented grad student, Niku, we were able to develop a mouse model of non-small cell lung cancer brain metastases, where we can inject these patient-derived lung tumor cells into the lungs of mice and have them track using bioluminescence the growth of a primary tumor. And over the course of 30 days, we can then explant the brain and we can see that it develops brain mets. So this is, a very powerful tool that we were able to develop at McMaster. And we were able to then leverage this tool to study different ways of treating lung to brain metastases. So, the other thing that I had a real privilege to be able to be involved in during the time was actually using a patient-derived tumor model to model recurrent disease. And this is a patient, an actual patient, 47-year-old female who had a history of recurrent GBM. And at the time of initial diagnosis, you can see this early stage GBM forming. And over the course of 2 years, she had multiple resections, both by Dr. Casper, who is my current mentor at St. Elizabeth's, has been a longtime mentor of mine, both at Harvard and McMaster University, where he was the chairman of neurosurgery, and Dr. Sheila Singh in her lab, and also Dr. Wyman, who was the head of the anatomical pathology lab at McMaster University. This multi-collaborative approach and this very, very generous donation by this patient herself to donate her brain and spine at the time of death. When this tumor overcame her brain, she said, I would love to have this opportunity to donate my brain and my spine to the Singh lab for research. And so, during that time, I was able to then coordinate a live, at the time of death, donation and harvesting of the brain of this patient. We were able to then section different parts of the brain, really kind of bank all this very valuable tumor tissue and do downstream translational research. So, it's really a glimpse into how, when everything really kind of falls into place with amazing mentorship and you put yourself in opportunities that allow you to hone your skills and expand your skills, that you can be, involved in some very, very cool research. And I've been very fortunate to have had that opportunity to do that. And after that experience at McMaster, I had the opportunity to come back down to the US and complete a very advanced neurosurgical fellowship at Northwell Health. And after that, here I am. at St. Elizabeth's Medical Center in Boston as an attending neurosurgeon, it's been such a, really a journey of 1,000 miles that began with a single step into the lab of Dr. Peter Reiner at University of British Columbia, and really kind of this journey that pretty much is not very typical of most surgeon scientists or most medical professionals. I think a lot of you are very used to this very kind of regimented 4 years of undergrad, 4 years of med school, 4 years of residency training. I think my story is more, you really look at the different opportunities along the way, and you take these opportunities, and hopefully you can grow and gain skills that will allow you then to carve out a career path that is fulfilling and interesting for yourself. And so what does it look like? What does my current life looks like? Well, my current life is quite interesting, and I'm very blessed to be able to have that opportunity to operate on brain tumor patients and patients with spine tumors. I've had a great opportunity to be able to mentor undergrads that are currently coming through the BU School of Medicine summer program in neuroscience, and here to do some teaching sessions with them in the pathology lab, looking at very interesting cases of oncology patients, and then bring them to the bedside and round with the patients who we've operated on, do a lot of teaching, and hopefully really interest them to pursue medicine, pursue clinical and surgical research as future physician scientists. And I am very lucky enough to be able to go to academic meetings, and here's the Society of Neuro-oncology meeting, and catch up with colleagues, and also, do patient advocacy, and especially since this is GBM Awareness Month, this is part of the National Brain Tumor Society event that we had last month, really kind of advocating for patients. And it's really important to let the patients know that we're there for them throughout the course of their treatment and as survivors, and bring together a great team of healthcare individuals who really makes my life happen at work. Nothing really happens as a silo. I'm also very fortunate enough to be part of Dr. Nino Kioka's lab at the Brigham. And unfortunately, this lab bench is looking very clean right now, because unfortunately I haven't really had time to do a lot of experiments. But hopefully, I'll be able to segue that into doing some more translational research as my career path continues to develop. So, the life of a neurosurgeon scientist is extremely interesting, and I'm very blessed to be able to have the opportunity to do a lot of different things that keep my mind interesting and activated. So, I thought I would share with everyone some of patient cases that I had the opportunity to treat. And case number one is a spontaneous intracerebral hemorrhage, and these are bleeds in the brain that can happen from a whole host of different situations. This 64-year-old right-handed male was found unconscious at home by a friend, and he was brought to a local emergency department, and he was found to be alert, confused, not following commands, but quite agitative. We also often give them a Glasgow Coma Scale score. I'm not going to go into the details of that. I'm going to show you what the CAT scan showed: a very large frontal temporal intracerebral hemorrhage. And anything on a CAT scan here, this is time 0, and everything you see here that is white and bright is fresh bleeding. So you can really appreciate, this is the brain, this is the front of the brain, this is the back of the brain, this is the right side of the brain, this is the left side of the brain. Anything that's bright within the brain here, I'm just going to say is fresh blood. So he had a very big clot in his brain, and it was causing a lot of pressure, and his level of consciousness was rapidly declining. And we had the opportunity to get him back to our OR very rapidly to be able to take this clot out. And I was able to take out what was safely I was able to safely take out the clot to alleviate pressure. And you can see post-op day 1, the clot is here, you don't see the clot there. Clot is here, you don't really see the clot there. Clot is here, you still see some clot, and I left that clot there just so that I didn't want to damage his brain any further. But at 3 months post-op, you can really see that, like other parts of the body, the brain is also quite good at getting rid of any kind of blood. So at 3 months, you really see nice resolution of the bleeding. And the patient himself did very well. He's able to perform his activities of daily living. He's able to change himself, shower and do all these important things that we need to do. He's working with a speech language pathologist and he's awaiting neuro rehabilitation. So, that's one of these very common situations that we are able to treat as surgeons. Case two is a gentleman who had a traumatic head injury. And we hear this in the news a lot. I fell and it hurt my head. So this was a 34-year-old male who was found down on the ground of a local supermarket. He was brought to a local emergency department. He was alert, but had altered mental status. And he was moving all of his arms and legs quite purposely. But, as time went on, he became more and more agitated. And when you look at his initial CAT scan, again, what you see here on the right-hand side, anything that's bright is bright. So he's got little bits of blood that we can see on the right side of the brain. And this was when he was first presented to the outside emergency department. And by the time we repeated the CAT scan at 6 hours, you can really see a lot more bleeding going on in the right side of the brain. You can also see these differences in the shading of the brain. And when you see this darkness in the brain, this really means that there's a lot more swelling that's going on. So his brain was really not behaving healthily in a way that, allowed us to say, hey, we should probably monitor him versus, is it time to take him to the OR and do an intervention, see what we can do, help this gentleman so that he doesn't continue to get sicker. So, the decision was to take him to the operating room and try to alleviate all that extra pressure in his brain. And one way we can do that is to remove the skull, the entire skull, along the side of the brain that is causing pressure. And here you can see what we did was I took out a very large part of the right side of his brain. And by doing that, I was able to decompress the brain and prevent the brain from continuing to swell inward and allowed the brain to expand outwards. And that really, it's almost like I'm going to use a very crude analogy of pimple popping. But once a pimple gets really big, the pus gets really tense in there and you pop it, releases the pressure, in a very crude way. So here we relieve the pressure of the brain by releasing the pressure by removing the skull. And, this is called a decompressive hemicraniectomy. After we did this procedure, the patient was able to wake up and he was alert and oriented, even though he didn't have much memory of the event. Here we can see on the post-op CAT scan that some of the original bruising in the brain has continued to grow a little bit. But because we've lifted off the bone, the brain is actually able to compensate outwards, and you don't see a lot of that dark swelling. And then neurologically, he did really, really well. And he was actually able to go home after, the 5th day of surgery with outpatient follow-up. So, these first two cases really tells the story of why neurosurgery is such a high intensity specialty, because these are really life and death situations. We don't have a lot of time to really think about, can we sit on these patients and see how they'll do, because if the brain swells and things don't go well, then they can decompensate and they can die. So, let's veer away from some of that and talk about some of the tumors that I often operate on. And case number 3 is the plano-sphenoidal meningioma. And meningiomas are tumors that grow from the lining of the brain. And I'll show a CAT scan that shows that after this. So this is a 76-year-old female who presented with several months of headaches and confusion and dizziness. Again, she was brought to the local emergency department, and an MRI showed an enhancing lesion. And here we can see here, anything that is bright in this particular MRI shows where the tumor is, kind of sits right at the skull base. And, it really lights up. It's very well circumscribed, but you can tell how much pressure it's really causing on the brain. And what we can see here when we look at the blood vessels is that the tumor is really supplied by blood vessels that are very delicate, so it's an area that has a lot of important anatomy, and we have to be very careful when we operate in that area. So, we were able to take her to the OR and do a very extensive craniotomy, where, like the first case, we take off the skull of the bone, we expose the brain, and we're able to sneak in and try to resect this tumor here. And we can see in the pre-op, here we have this tumor, and in the post-op, we've done a pretty good job at removing most of the tumor. And the patient's done quite well. She's woke up post-op day 1, and we had near complete resection of this meningioma. So, this is also very interesting when we also, not only in the brain, I also operate on tumors in the spine. And, in this case number 4, we had a 37-year-old male with a history of a trauma to his neck, presented to my clinic with neck pain and weakness in his hands and his triceps and his biceps. And here we can see on the X-ray, here's a normal looking bone in the spine. And here we see this really crunched down vertebrae in C7. And on the MRI, you can really see how the 7th vertebrae is quite crunched down. It's pressing down against the spinal cord, and his nerves, which is really what's causing his neurological symptoms. So what we were able to do is we were able to go in and remove this bone, this broken bone, completely, and then reconstruct his spine with a titanium cage and a plate. And as it turns out, this patient not only just had a trauma to his spine, it turned out this bone was abnormal, and he ended up being diagnosed with a plasma cell tumor. So it's really interesting how, some things can turn out being traumatic and end up being something different. And these are cases that, I've had a lot of interesting opportunities to teach some undergrads about the different types of tumors that can happen in both the brain and the spine. And my final case really hits home the severity of brain metastases. So this is an 80-year-old male who had a several-month history of confusion and headaches. And here on his MRI, you can see a bright, very well circumscribed, very well delineated tumor, very deep in the lesion, deep inside his brain. Interestingly, we also saw a lesion up on the scalp, and he had a remote history of melanoma in his back that was removed years ago. So the question was, is this lesion related to this lesion in his scalp? And when we looked at a different type of CAT scan, we were able to see that the lesion on his scalp was actually quite large, and it had this pedicle that really just kind of stuck to the skull of his, the outer part of his skull. So, my hypothesis was, is it possible that this lesion here, the cells could track down through the skull and land somewhere deep in the brain? So what I did was I excised this scalp lesion and sent it for pathology, and it showed malignant melanoma. And to go deep into the brain, we used a stereotactic device where we can use almost like a 3D GPS system, and we can image guide this very thin needle, fine needle, deep into the brain and take some samples from here, because it's way too deep to really kind of do an invasive surgery on an 80-year-old gentleman. And pathology from this stereotactic biopsy also demonstrated metastatic melanoma. So, this is a very interesting, hopefully these 5 cases really hits home all the different types of surgeries that, as a neurosurgical oncologist, I have the opportunity to partake in a wide breadth of different types of techniques to treat a wide breadth of different types of neurosurgical emergencies. Some of them aren't emergencies, but they need to be treated because of the effects of some of these tumors with pressures on the brain and neurological effects. And also, we need to figure out how we can
always be doing B&D because you have fibrotic tissue creating.
Treat these patients with novel therapies once we get a diagnosis of what types of tumors these patients are growing. So a few words of advice, for those of you who want to pursue neurosurgery or want to pursue medical research or become a clinician scientist, what has guided me and what has served me well in terms of getting to where I am today. Find multiple mentors. It's really, really important to be able to help steer you throughout all these complicated facets of career development. I wasn't sure early on whether or not I wanted to commit myself to a long career of medicine and surgery. I was very happy in the lab and had great mentorship, did some very exciting translational research. But thankfully, throughout the years, I had multiple mentors guide me and give me opportunities to further develop my skill sets. And, it's also very important to develop multiple skill sets, but don't be a jack of all trades, master of none. Become an expert in whatever you think is you're passionate about. Do your best in becoming the top of your skill set and being able to publish some really cool papers or being a skilled surgeon, because this will also help when sometimes the training is very arduous and you have long hours either in the lab or in the hospital, and if you don't have that passion and focus, sometimes it can really things can get tough, which is also important to maintain work-life balance. All work and no play is no fun, and that's something that I'm constantly uh, uh, you know uh, being mindful of. And I have a lot of great friends and colleagues and network that really helps me kind of bring that together in my life. And, have backup plans. Life is an ever-changing landscape, and sometimes you may not get where you want to be right away. And sometimes you have to kind of have backup plans that kind of brings you back to where you are now or where you really want to be, or what you really want to do. And, many of you are early on in your career and really kind of exploring a lot of these interests. So it's important to have plan B, plan C, just in case something changes or you lose interest in one thing, and you have the opportunity to then develop, use your other multiple skill sets to then pursue other focuses that are equally fulfilling. So that's kind of my story. And I'll end here and thank you for this honor and opportunity to speak to this audience. I wish everyone every success in your future endeavors, and I will open the floor to any questions. And thank you for your time.